sadly, your cancer can disrupt your daily living. It's also, if you're unable to travel easily or do your daily activities easily, it also means you may not be able to go to the hospital to get your follow-up care. So your access to care can be affected, and it of course can affect how you are able to contribute to your family and your household, thus affecting you socially as well. Okay? So just a couple of quick quotes. So like some of our patients said, like the first one on the left, if I have a stoma bag, it's difficult to care for it. If I'm at home, I can just use the sink. If I'm outside the workplace, I need to use the toilet. This patient expressed to us how that made her very isolated because she no longer felt it was convenient to travel or to go with her friends, and it limited what she could also do on a day-to-day basis outside of the home. On the right side, when you feel so sick, you feel you've neglected your whole family, I feel bad. I feel bad for not being able to do the things I'm able to do. I feel bad for not being able to care for my family. Okay? And at the bottom left, this is when you become very lonely when you have this kind of disease, right? So having cancer and with all the suffering that it causes really has a significant impact on your activity of daily life. Second theme was, of course, its impact on the psychosocial and spiritual. So therefore, the patients told us that it's really important to be able to have this support system. And there were all these fears being raised up by our patients, the fear of being a burden, the fact that they felt they were socially isolated, but there was very limited support to help them once again become more socially active. Because you cannot just tell someone, go out and mingle more, go out and make friends. Well, again, if you are that patient with the stoma bag, or if you're unable to travel, there's nobody to support your travel, etc., you can't be able to do that. Okay? There's also very limited information provided about where to seek for support. We've had many patients tell us, I'm grieving, but I don't know where to seek for help for grief. Yeah? I'm not depressed, I'm not there yet, I don't have clinical anxiety, but I'm sad, but I don't know where to seek for help. Right? So there is a need for that. There is a need to be seen still as a person and not a diagnosis. Right? There is, of course, cases of anxiety, depression. Crucially, there is a need for hope. Right? And many of the stage 4 patients did tell us that, hearing words from caregivers, from their doctors, often diminish that sense of hope, which then reduce their overall well-being and quality of life. But also importantly, the need to feel normal and the need to feel in control, to be able to have agency and still do the things that they always used to do. Right? So again, some representative quotes. Even for patients who are doing well, or like for example on the right side, there can still be a lot of anxiety because, like for this patient, I'm a bit anxious to find the results in September because it's 1 year after the removal. I don't know whether the results will come out negative or if it's spread elsewhere. Now, with this level of anxiety, you probably would not get to see a psychiatrist or any specialist to get medical treatment for this. But there is still anxiety, there is still suffering here, and there is still need for help. But often, these are the kinds of people who are least able to actually get the help that they need. So there is also, of course, a significant need for information, valid, trusted information, because when our patients related to us, when they got cancer, they have 1,001 questions, and they also get 1,001 answers, but you don't know which answers to trust and which answers to value, and to some questions, there are no answers, or they are difficult to find. And so these are questions about, for example, if they get an end-of-life diagnosis, how long do I have, etc., and how should I manage that? Dietary advice, what do I eat, what can I eat, what can I not eat? Especially in our Asian culture, we have a lot of pantang and all that kind of thing. But if I adhere to every single pantang, it means I only eat plain white porridge every day. And then also some people will tell me it's bad, right? So then what do? Don't eat it? And that also is bad. So you can never please all the people who give advice to you, right? So what is a good dietary advice? How to manage your symptoms, and that's where they really needed good, effective communication from their doctors and nurses. And what about alternative treatment? When nothing else works, what about alternative treatment? And of course, what about palliative care in the end? Okay? So I'll just zoom past this, right? Next please. And of course, financial need. Financial need is one of those things where in the clinic, in the hospital, it is at the very end of the conversation before people say goodbye to you. Right? Oh, you need money, here's a form to fill up. But from our interviews, financial need is almost synonymous with, or rather financial health is almost synonymous with physical health. Right? If you have no money, you cannot get healthcare. If you have no money, you will be sick and then your condition will get worse. You cannot feed your family, you cannot do the things that you need to do, you cannot feed yourself. So it's really important. There's all sorts of need to be able to be well. And of course these are struggles. So really I want to finish up with some points to consider. Many advanced cancer patients, you have a lot of highly important unmet supportive needs, and we know that if we are able to address these needs early on, we can actually improve well-being as much as possible. Okay, and again, all too often our focus tends to be on curative treatment and on clinical symptom management, but this is really one small aspect of the cancer experience for all our patients and caregivers, and so all of this needs support. So I just want to emphasize the very last point is that cancer care is really not just clinical care, and it requires a whole of society approach in order to improve the quality of life and well-being of our patients and their caregivers. With that, I thank you.
Thank you very much, Dr. Mark, and to both our speakers once again for the very insightful and fantastic talks. So Dr. Mark brought up a very important point which I had not addressed today. So I would just like to ask, are there any members in this room who are members of this audience who are cancer survivors, people living with cancer or the cancer or the caregivers? May I have a show of hands? Wow. So can we all give them a big hand? Thank you very much for being here, and it is our pleasure to host you today. So for the question and answer session, may I see if there are any members of the audience who might have a question for one of our speakers? If you do, could you kindly state your name, your primary affiliation, and then your question? If there are no zooming hands up, where I have questions. So my first question is to Associate Professor Dr. Piani. I was wondering about your study, the one with the skin temperature. So, and your measurements of stress before and after the program. Do you see any differences in individuals who maybe have very busy family lives or very busy work lives, how the program may affect them differently from people who generally have more, not to say relaxed, but less demanding lives in terms of your workplace or your family?
So only the skin temperature?
Or maybe general.
Yes. So let's maybe reflect on that. Of course, majority of cancer survivors then join the program, and most of the time I call them cancer warrior. So they are brave people. So that's beyond the survivor. So of course, there are multiple factors like the work, the stress, the family member. Of course, for people who have less, responsibility, so they'll be tend to be more relaxed and they can let go things better. But it's not always. It's not always. There's some people who really have to work, even though they have to go through the treatment and also another responsibility. They also can function well, right? And one of the key things that they share with me is positivity. Yeah. So I think that's quite a powerful word. They said, there's all a lot of issues, but if you kind of like have a positive attitude towards it, you can feel like you can do anything, then you can do it. So it's the attitude. And so then with that case, they can manage things better during the session, even though amid the stressful situation, they remain relaxed, and with measuring of the stress thermometer, you can see the change. And in the current project, we also measuring the heart rate. That even show the change faster. So some participants in the session in the beginning, they said, I feel so stressed, there's so many things. Then after talking with the group, after doing some practice, the heart rate dropped. I remember one of the case like 100 dropped to 80 something, so they said they feel better. So again, it's not just the stress, it's about how you perceive it, how you approach the stress in our life.
Yeah, I was thinking perhaps the ones who have very demanding lives, they may practice the mindfulness even for their normal life. So maybe it goes from this to this, and then the ones left behind maybe this.
I see.
So it could be an interesting thing to look at if you have the information. Yeah, yeah. And then my second question was about the current study. You have 3 groups: general mindfulness and MindCan. Yeah, I wonder if you could elaborate a little bit about how MindCan differs from general mindfulness.
Yeah. Thank you for asking that. I didn't have time to explain during the session. Yeah. So the general mindfulness is been developed long time ago by Professor John Kabat-Zinn. And in that program, it's only teach about mindfulness session, mindfulness practice, like mindful breathing, body scan. It didn't have the education component or that specific for cancer. And I feel like maybe we have to add something to it. So let's look at his presentation over there. So the second presenter, so he presented the need for information. So that's why we add the information to the program. And we call it the MindCan program. So we feel like people can do anything that we set our mind to. So the MindCan program has 2 components. The first component is the education one. So we kind of like specific, put the information that's specific to cancer. For example, if we talk about stress, the first session, we talk about what kind of stress that link to, the disease. Could be treatment, could be side effect, could be a lot of things. So when they talk about thought or emotion, so what are the feelings that may link to the cancer survivor? Could be depression, anxiety, sadness, nervousness, a lot of things. So we focus on anger sometimes. So we focus on that emotion. For the thought, one of the key things that maybe to present during the time of the treatment is that, why me? Why this thing happened to me? Why not my neighbor? So why me? So then, or is it the fear? Is it going to come again? How about my chemo brain? So those kind of things. So we kind of like the session was specifically path and tailor address those issues linked to cancer survivor. So that's the difference between 2 programs. So more specific on cancer survivor issue.
Any questions, perhaps?
Any questions?
I have a question actually to either speakers. I know we are focusing more on the cancer patient and the survivors, but is there anything that you have done for the carers of the patients? Because they are also going through the whole process of grieving of the diagnosis and not knowing what's going to happen in the future, especially financial. When you lose one person who's probably a breadwinner in the family, and they are going to go through without them, and it's, I don't know, you don't know what's going to what they are going to face in the future. So in terms of like anger or denial and feeling sad that somebody's sick, it's their loved ones, and it's almost probably helplessness that they can't do anything much. So I don't know, perhaps both can answer.
Thank you for the question, and I think certainly from a lot of our work, we acknowledge actually it's not just a side topic, it's a very crucial importance to take care of the caregivers as well as you take care of patients. In advanced cancer and as well as in many other life-limiting illnesses such as dementia, the way we perceive it is that these illnesses are 2-person illnesses. The primary caregiver and the patient are intertwined and their health is related to one another. So certainly we found it to be really important to care for the caregiver as well and to also study their needs. Some of the research that my team has done focusing on caregivers of patients with life-limiting illnesses, we've also studied their needs, and their needs are sometimes a little bit different from the caregiver itself. So for example, some of our common assumptions would be that caregivers would like to be able to have somebody take that burden away from them. Caregiving is a burden. But when we do the studies in Malaysia, we learn that for many caregivers, caregiving is not just a burden, it is actually a privilege. And they don't want it to be taken away from them. Oftentimes what is communicated to us is that what we need is to receive supportive help in terms of finances, in terms of to be able to deal with all the other parts of my life so that I can further take care of my family member who is currently sick with illness. When we've offered to do things like, what if I send a nurse to your home to take care of your mom or your dad while you go off to work, oftentimes that's rejected because they feel that it is my role and it's my privilege to care for my family member. I need support in these other ways. So we have found it really important, in a nutshell, to study the specific needs of caregivers of patients with life-limiting illnesses, because we cannot just assume, and it does differ from culture to culture.
So yeah, thanks for the question. For my program, even though it's offered for the cancer survivor, but we also welcome caregiver. So there's multiple occasions that the relative also sit in and practice with us. Actually, it's better. They try to know what are their relatives, their loved ones learning throughout the program. So that's what we do. But that's now so far from my side, I haven't had any specific program for caregiver yet. But in Singapore, all the hospital, they would have some program. They would have some support group for the caregiver. So in not just only cancer, but in other chronic condition as well. So I think that's even much more comfortable for them. So they can form a group together, they can discuss the issues, support each other. So I think it's very therapeutic. You're welcome.
My question to you, Mark, actually, for your study, the one with the baseline and the 6 months, right? Do you see any difference between the cancer types or cancer stages for the patient, those with advanced stages?
Well, there were minor differences between the different types of cancer, but nothing too significant to elaborate around. But in terms of stages, we did see, of course, for example, those who were at stage 4 were placed a much greater emphasis on being able to die at home, to be able to choose their place of death, as opposed to those over at stage 3. So I think, what we've noted is that as patients' disease progresses with time, as they go from stage 3 to stage 4 as well, what will happen in between is it's not static. So their condition changes, they get additional advice from their doctor, their treatment direction changes. So that actually leads them to change in their preferences as well with time.
And then I noticed that social dysfunction was the one, just a quick glance, but maybe it's not the top one that dropped, but I noticed that it had the biggest drop in monetary value at baseline and at treatment. So could you elaborate why you think that's the
Well, it's not entirely clear to us why the value placed on social dysfunction actually dropped. But I think because these are again relative values, so what's happened is that as patients' condition steadily got worse, they place a much greater value now on being able to stay healthy and take care of themselves, perhaps at the expense of, let's say, being able to socialize outside. So it was more of a shifting of values rather than to say that being able to socially function is no longer important.
Okay, so when they fill in the questionnaire, they literally give a monetary value.
So we have monetary values attached. It's a rather complicated questionnaire asking them, if you have these sets of circumstances and you have to pay this much of money, would you prefer option A or option B? And then we keep on doing trade-offs. So at the end of the day, we are able to do some logistic regressions to end up see, well, relative to one another, which are the values which are most important and which are the ones you would be willing to pay the most money for.
Because this is tied to a monetary value, I wonder if it's because they realize at that point for social positioning or status, it's like if you have it, you don't need to pay for it. If you don't have it, no matter how much you pay, you won't get it. So they might put the money
not necessarily, because I think for many of the patients that we did interview and did money is important not only for themselves, but it's also crucial to minimize financial costs because of the implications on the family and caregivers. In fact, for many patients, especially, what we find is that cost becomes much more important towards the end, because there is this desire to conserve as much financial resources as possible to be passed on to the next generation or not to burden the next generation. Yeah. So most of them are no longer thinking about their own finances from their own perspective, but the implications for the family and dependents.
I've got a question. How much is mindfulness, awareness of mindfulness among the cancer survivors? Do you know, in Malaysia, for instance?
How much awareness?
Awareness of mindfulness, practice of mindfulness.
Oh, in
among,
Malaysia?
yeah.
Oh, I'm not sure.
Okay,
That's
but
a
what
very
about
good
it?
question. Yeah, very good
Yeah.
question. Yeah.
Is it now like increasing? Let's take Singapore. Is it increasing?
So far, I hope it's increasing because we started to introduce the program 8 years ago. So of course, the people who join the group, probably they have awareness of the mindfulness. Yeah. So, but I think for Malaysia, I have no information yet.
I see. Okay.
Right.
Given a chance, would you start one in Malaysia?
Oh, I would love to. So actually now I'm offering the online mindfulness. You're free to join.
Oh,
Yeah, I think you're free to join the program caregiver, and then we offer. We also still collect data, but for observer, we have some observer just to join, not for the sake of research, but for the sake of learning. So we are also welcome those. Yeah, you can even you have my contact information. You can send me an email. We can
Maybe
give
you
you
can
the
show the
contact.
slide on the
Or do you have a website?
Oh, yeah, I will share with you. Yeah. So
Okay.
yeah, so I'll share with the. Then you can just join. We
Do you
a
have
website.
it at any point on your slide?
Or can
Okay, let's see.
Can
Yeah,
you
I
Google
do
it
the
now?
first page. First page. First
or
page.
you have it on your website?
Second page. I think I do. Otherwise, I can type now.
While they're looking for it.
Yeah. So welcome to join that. And I think most of the time when we go through this kind of journey, sometimes we worry too much about the future, like what's gonna happen. And so the thing that I like to tell you is we need to focus on today. We do things one day at a time. Yeah. So the message from mindfulness would be make today the best. Because today is the best foundation for the future. Just focus on today. Go make today, one at a time. Just otherwise, our mind is thinking about what's going to happen, what is the life going to be. I mean, we may be just worried about something for free. It might not be happening, right? So just focus on the happiness or mindfulness that we have right now at this point.
Okay.
And a lot of patients who join the session, I think it's good. Is it too small? Otherwise, I can type it.
Yeah.
Right. NURPK. Yeah. Sorry about that. How can I forget that? NURPK at NUS.edu.sg.
Oh, so this is your email?
Yes, my email. My
Oh,
email. So
maybe I'll put it here.
So fortunately, we got a grant to offer the program until next year, next August 2025. So, so yeah, so please join us, and I'm very happy to do that. We have multiple groups, and most of the time we allow time for the comfort for the survivor, because sometimes they work, sometimes they prefer Saturday. So Saturday, Sunday, I'm also fine to offer the session. Yeah.
So you've got like a group of people from Malaysia, then you accommodate the timing, is it?
We can talk about it. We can work on that. Yes.
Alright, thank
So
you.
probably we have to think about we can work on that, I think.
Okay.
So I don't know yet how many people will join. So this one can be worked
We'll
out.
spread the word.
Yeah. Right. I think I would love to. Yes. Yeah. Please spread the word and share and join us. Yeah. I would love to see all you guys.
So coming back to, so in your research or studies that you've done with the survivors, have you ever talked about mindfulness?
We have actually spoken about with regards for information, the need for information. So one of the, for psychological/spiritual support, one of the things that does come up occasionally is mindfulness and other, let's say, meditative techniques. Because we do find that as much as patients do want, of course, external help, they want some hotline and all that, many of them do request additionally to be able to be taught skills whereby they are able to address these, let's say, psychological distress themselves. So oftentimes we find that, and it's not just, we see the same thing for many other types of dysfunction as well. Patients will want, of course, some external support, but very loudly we will hear, we would like to get some forms of therapy, some forms of training that can allow us to be able to take care of ourselves to address these symptoms as well. So one, for example, I'm deviating from the topic a bit, but one major request has always been, I need more occupational therapy. Because if my cancer puts me in a wheelchair, my wheelchair is not a disability if you can teach me to do my household chores while on the wheelchair. The wheelchair is not a problem. My ability to do my cooking and my laundry and my gardening, all that, if I cannot do that, then that's a problem. But if you can teach me how to do that on the wheelchair, I have no problems. So they need that kind of therapy, and likewise, again, coming back to psychological need, if we can educate and provide more training on coping strategies, mindfulness, etc., then that goes a long way in improving patients' independence, agency, autonomy, and therefore well-being.
My question is for Mark. It might be hard for you to answer in the next few minutes, but it's a what next. If the patient's needs are to be considered in their care and treatment, how do you envision the reframing of their care, and how can clinicians refer them on if clinicians themselves have limitations in addressing this?
So I think a lot of the underlying reason for us doing this research was to raise awareness among clinicians and healthcare administrators to understand that, number one, on a larger level, cancer care requires more than just clinical care. And so what we've often found through the interviews of patients telling us their experiences interacting with doctors in the clinic is that it always focuses on the clinical. And even when our doctors ask us, so how are you doing, it tends to be superficial, just out of courtesy, rather than any real exploration about how they are actually doing. And so we've done some of these studies with the primary aim of getting clinicians to think about, if they can, find that additional bit of time to explore these things. So research like this highlights which are the areas that you may have, a doctor may have often ignored in their day-to-day practice, and for them to get to start thinking about asking these questions. Like we are currently doing a study right now on sexual health among advanced cancer patients. Nobody asks patients about their sexual health. And they don't ask, a patient is, with all due respect to all the patients here, a patient is not going to come out and suddenly volunteer to their doctor, hey, I want to tell you about my sexual health. It's unlikely to happen. Right? So we need to start identifying that this is an important area, and from our ongoing research we are seeing that it is an important area for general well-being. Okay? And we are not just talking about intercourse, we are talking about intimacy, loving relationships, and all of that is affected by cancer, but nobody talks about it and nobody asks about it. So as we start flagging this, we start giving clinicians an indication that this is important. We are in the process of trying to at least design a couple of questions that clinicians can use in the clinic. Okay? But it also, on a larger level, on perhaps a more public health level, is for us to start thinking when we design cancer care guidelines or cancer care policies to ensure that social welfare, financial aid, etc. is not moved to a small negligible corner. It gets us to start thinking about the fact that maybe our healthcare system requires more social workers, more responsive financial aid agencies. We need to reduce the barriers to access to all these forms of support. What we see in our current Malaysian system is that everything requires a referral. And we think that it's a system that streamlines and makes things more efficient. It is not. From the experience of our patients, it is not. What these referral pathways have become, they have become obstacle courses. You want to get financial aid? These are 10 hoops you jump through. And if you successfully make it, congratulations, you are sincere enough, I give you the money. That should not be the way, and hopefully this is our grander aim in trying to do this, and in the long term, hoping to reshape how we provide cancer care.
Yeah, nicely at 10:10. We were initially supposed to end at 10 o'clock, but if there are any more questions, we can still take them. But if not, then I will, before I end this session, of course, we have to present our two speakers with the tokens of appreciation. May I invite Professor Elu to help present the tokens to our speakers? Smartphones now can sing so far.
Thank you.
Thank you very much.
Thank you so much.
Mark, thank you very much.
I'm not sure if you guys want to take photos.
Yeah. Alicia, come join us. as well.
I'll stand at one side.
Yeah,
if you
yeah,
like.
yeah.
Cool.
Thank
you very much.
Thanks a lot.
Alright, with that, I will bring this session to a close. I am told the coffee will be ready by 10 o'clock, so feel free to have your coffee break before the next session. Thank you all very much, and see you again in day 3 of our NCCM.